and we try to promise you a very good session this morning. Thank you for everybody coming. Our theme is towards perfection in lacrimal surgery. Without much ado, I would like to call our first speaker, who will be giving a lecture on suturing of flaps in Endonasal DCR, Dr. Nattawut Wanumkarng. Dr. Nattawut is actually you are the head of the Division of Ophthalmic Plastic and Reconstructive Surgery at Pungrunggrad International Hospital. So, Dr. Nattawut.
Good morning, dear friends and colleagues. Thank you, Ray, for a kind invitation. Today, my talk will share with you about my experience that I have learned since I started to do the endoscopic DCR in 2004. In 2006, I starting to thinking about how can we do the flap suturing. And initially, on the first practice, the knowledge, know-how, and the experience not that much. The success rate is not that high, only 88%. But when we learn and develop, learn more technique. I introduced with the create a good bony ostium and the flap suturing. So eventually we can make the success rate much better. In the digital anatomy, we can learn how to perform bone removing by the endoscopic frontal process of maxillary bone, lacrimal bone, and the ethmoid bone. So the concept that we divide the bone to be two parts. The first part, the ideal is that need to be removed very good for the lower two-third, and second, very good for the upper one-third. That related to the medial wall and lateral wall of the lacrimal sac. That allow the surgeon to perform the flap very good. So the first one, the needle and the suture. What kind of suture is good? The best suture that I use is a 6OYQ. 8 millimeter that be enough for the narrow cavity of the nasal and the length of and the type of the needle need to be spatula, but the spatula needle have the sharp at the tip point and the lateral part. So do not use a cutting needle because it can cut through the nasal mucosa and lacrimal mucosa. Next, the flap classification. We divide to be four classification. The simple first one is anterior, posterior, and the superior and inferior. For the second one is the third and fourth is isolated flap and the combined flap. That's used for difficult case. In the first video, I show and share with you about the anterior and the posterior flap suturing. Initially, need the assistant to hold the camera in the opposite side of the table, and you teach your assistant to hold the camera very good, like a two part of the bridge. Your hand is one pole, and the four of the node, especially located in the infromedially, and let the assistant hold the endoscope really steady and don't stress or pressure them, and then let them introduce the endoscope 1 millimeter in front and 1 millimeter in the back, and keep steady like this. And that allow you to have your two-hand technique for perform the suturing. Sometimes we do most of the my favorite one is anterior flap suturing. And sometimes you can perform the posterior flap suturing also. That not, but a little bit more difficult because of sometimes the nasal narrowing of the nasal cavity and not adequate of the mucosal tissue. And the second one is the superior and inferior flap. This is a good one for the distended sac from the chronic or acute dacryocystitis. We just make the simple head-shaped incision and elevate that up to the superior, and the inferior flap will come down. For the combined flap, this is good. This is applied for the revision case and isolated flap also. And I will show you later about this one. So for the challenging case, the surgeon need to know the principle and the pathophysiologic of the revision. So know the cicatricial tissue and the degree of the bony osteum. Let's start with the first one, isolated superior flap. This is a challenging case. This is a failed case that have a very thick scar tissue. Previous surgeon removed partially of the bone, but did not remove the upper 1/3. It removed only lower 2/3. So when you perform the revision, you can see after making the C-shaped flap, very thick scar have been found, and we can see that the upper 1/3 have not been removed yet. With the simple technique of the chisel and the mallet can remove the bone easily. We found that the Asian people, Thai people, Chinese people have the very thick bone, especially on the upper 1/3 of the frontal fossa. The Indian patient, Caucasian patient, with the thin bone, very more easier. And in this case, they have a very thick scar at the common caniculi. I think about, can we make the horizontal incision and make the scar tissue and imitate like a superior flap and elevate it up and try to suturing the superior flap to the upper part of the nasal mucosa. In this case, because we not try to aggressively cut the scar tissue and we release the scar tissue a little bit and put the silicone stent, there are a lot of high % of the fail again. In my life, maximum time that I did revision is about 5 times until I discovered this concept. So flap suturing is going to be quite a big benefit for the case of the revision. In this case, you do everything that can help for promote the success rate. Put the silicone tube, inject the 40 milligram per cc of the steroid, and then put the gel foam and sew it with this one. That's very helpful. So the next one, isolated anterior flap. This is another tough one that had to fail for multiple times of the external DCR with the small osteum. This is some kind of the subtype of the Sum syndrome. They have a couple subtype of the Sum syndrome, and this is called the Sum syndrome. That the medial wall of the lacrimal sac, they have scar tissue according to the lead area. So when we apply, we use a 45 up and 45 down test for checking about the adequacy of the bone. At that moment, the surgeon will know how adequate it is. In this case, 45 up is negative because of the upper 1/3 of the frontal fossa had not been removed. So we need to do the new job. So after creating the bone, creating the anterior flap, you can see the really thick scar. If in this case we did not perform the flap suturing, there are a lot of high % that the anterior flap would rotate posteriorly and closing the wound again, even though we've tried to put the silicone tube. One stitch may not enough. I do recommend 2 stitches of the anterior flap, one in the upper, one in the lower. And in this case, just simple, not surgical knot would be enough. For the isolated posterior flap suturing, this is good for the Sum syndrome. This is another subtype of the Sum syndrome that have the a tiny opening in the upper part and the well-defined and well-healed of the internal lacrimal sac mucosa. We just make and the previous surgeon only opened on the lower 2/3, so did not open in the upper 1/3. But internal lacrimal sac mucosa heal scar really well. So just make a simple vertical cut and rotate the flap posteriorly, and just one simple posterior flap suturing, that would be enough. In this case, I'm pretty sure that without the silicone stent, it would be fine. But even though we do everything, try to increase the success rate nearly to 100%. So in this case, with this technique can be cured really easy. 1%, 2% can be the failed DCR. In this case, I perform a very good bone, I perform very good flap suturing, but the patient is an Ethiopian. He flew to Thailand, and then after 1 week, he left back for 6 months. Did not clean the nasal mucosa very well. So the dirty nasal crust initiate the inflammation, initiate the granulation, initiate the scar tissue. So they initiate the thick, moderate thick scar tissue at the common canaliculus. In this case, simply just vertical cut and make the anterior flap and try to do this flap. I did revision this one in the outpatient department. No need to go to the operation room, just endoscope and then just a simple and then steroid injection, that would be fine. And the next one, continuous interlocking suture. This one I just found that is quite helpful, but may need to keep learning for a while. And this is imitate like interlocking flaps suturing that helpful maximize approximation of the lacrimal sac mucosa and nasal mucosa. In this case, the benefit is to stop breathing and try to approximate the flap maximally. And this is just a trick. You may not need to do it in every case, but this is you have a concept. When we have the concept in our mind, in the surgical time, we can choose any concept for correct this one. Many times that we do the endoscopic DCR and the nasal cavity is so narrow, marked septal deviation to the right on this patient. So we think about, oh, we're not the ENT guy, I'm not comfortable, I never done the septoplasty in my life, I just put it. I use the fear to put it, and I think about how to maintain it. I use a cotton ball tip, just put it in the superiorly of the upmost of the nasal cavity. Sometimes you can use a Q-tip and broken and put it in the upper part and keep it for a 2 or 3 or 4 millimeter that you get more space that allow you to perform the endoscopic DCR really well. So conclusion, benefit of the flap suturing can increasing the success rate of DCR from 95 to 99%. Flap suturing require high learning curve. Endoscopic flap suturing could be efficiently applied for primary and secondary failed DCR. Thank you very much.
Thank you very much for having me. That was an excellent lecture as always.